session, and he will join us shortly. So, I'm not very good at staying still, so I'm going to walk around a bit. So, we asked before that a number of people had EDS. Does everybody know what we mean by EDS? Everyone happy? They understand? People who've just had a Chiari may have never heard of it. Certainly many in the medical profession have never heard of it. People not sure? Shall I just give you So there's been a lot of interest in a number of places about Ehlers, we call it Ehlers-Danlos, or it's hypomobility. Now, hypomobility in the normal population can be normal. We see lots of people with hypomobility. You think of all your gymnasts have hypermobility, and they may not have much in the way of symptoms from it. But in a small group of patients, they can be very symptomatic from a number of reasons, and that can affect their body. The interest is particularly at the craniocervical junction. And it came in initially from a paper published over 20 years ago now by Thomas Millerat, where they looked at vast numbers of people with Chiaris. They're actually measuring to see what the cause of the Chiari symptoms were. And they found that while most of them had a small posterior fossa, a small proportion, or about 10%, had symptoms of a Chiari and had excessive mobility. And so it came around this idea that in a group of these patients, fixation of the craniocervical junction might be of benefit. Now, people with hypermobility, there are a number of types of hypermobility, and the vast majority of the types you can check from a genetic basis, and there's a genetic test for. But there's a certain type called Ehlers-Danlos, or the hypermobility type, that has now been, there's a set of criteria that were published in 2017 that set out what it means to have that, how you make that diagnosis. Not everyone accepts those criteria. Certainly, when I speak to rheumatologists in the UK, a lot of them don't accept that criteria. And I think what we've seen, and it sounds like it's very similar in Canada, that in the UK, there's a lot of patients who have been diagnosed with hypermobility, who have symptoms, where they go to their local service and they don't know anything about it, and they don't accept that there's a problem and that it exists, and they're crowdfunding and they're going elsewhere, either to the US or there's a particularly aggressive surgeon in Spain where they go to. And so from the UK point of view, what's happening is, as a national process, we're looking at the evidence and trying to work out how best to treat these people. But it's a really interesting topic. And so within the conference, there was debate and discussion about that. Now, one of the problems that there is out there is that, as Marcus spoke earlier about the levels of evidence, we like evidence. As a surgeon, I like operating, I like doing operations. But if I'm doing something that I haven't done before for a condition, I want to have a feeling that it actually helps that patient. And so the way we do that is I look in the literature. Now, this has been done for 20 years, this surgery. I know of surgeons that have done them more than 1,000 cases. The first publication on outcomes for this condition was this year, of 20 patients. The first publication. To me, that says something, and that's one of the reasons it's been so difficult for this to get accepted by other parts of the medical community. But so the conference was very interesting, and actually what I think has been very good is that the people who proposed the procedure, a couple of the surgeons from the US, and it's starting to gain popularity across some centers within the US, are willing to engage in the discussion and talk and think about it and think about how they can prove, one, that it works, but two, look at who might benefit from it more. So within the conference, we had 2 sessions on hypermobility. The first session was led by Fraser Henderson, who, as many of you will know, has published a lot on this, is a real proponent of treatment for this condition. And he gave his view of the pathophysiological causes and how he looks at treating patients. We then had further discussion. There was a talk from Jeff Wilson. There was a little bit more the more traditional view, hold on, where's the evidence for this? We talked about now Jörg Kleekamp, who is a German neurosurgeon who is absolutely meticulous. He records every patient he treats. he looks at them before, he looks at them afterwards, and he has a database of 4,000 or 5,000 patients. And so when he says, I've looked at my patient group and they were better or they weren't better, and this is what I did, you listen to what he says. Now, he was talking about basilar invagination. There was a lot of debate about what that means. So just to explain what that means, you've all seen, I presume you've all seen scans taken down the midline of the brain where the Chiari is. And the bit of the brainstem sitting there, there was a lot of debate about, is it that there's pressure on the brainstem from the front, and this is causing some of the symptoms that people are have with EDS and this diagnosis of instability there? Or is it that with pushing into the brainstem, it's sort of pulling and pushing the brain, and that's causing the symptoms? And so basilar invagination is when there's evidence of compression, when you can see something pushing in the brainstem. A lot of the diagnosis, or the ways people diagnose this for this condition, have come out from this idea that it's pulling and pushing. So they do various measurements, and those of you who have EDS and have been through you'll know the different measurements they do and on the sort of imaging they do, and that's some of the questions that'll highlight. For others, they look at the angulation, they look at the difference in the top of the spine to see how much movement there is there. So we did talk about that quite a lot. Talked about ME associated with hypermobility, and then there was a second session on Ehlers Danlos, talking about some of the morphometrics in EDS patients, and looking at surgical approaches. Lindsay Wilson for the Canadian group looked at so there was an expert panel recommendation published in Canada for the management of these patients. And what she did was she looked through and said, was it well done? Basically, was the review well done? And the short answer was probably not, in that from a recommendation point of view, it didn't really go through it as well as it could have and look in as much detail, and the recommendations weren't that good. So what was then interesting was the last session was talking about where there was agreement within the group of surgeons, clinicians, and scientists there for what you could say from a statement point for EDS. So the first statement was, because one of the questions is if somebody with EDS has a Chiari malformation, should they be treated differently than somebody who has a Chiari malformation without EDS? And what it came down to was, what were the symptoms? So if you have classic, really bad headache when you cough, and the things that one would expect to see if you have a Chiari malformation, then everyone agreed, and it's unusual to get a bunch of doctors to agree, but everyone agreed that they would treat them the same as the first line treatment. Whether you had EDS or not, if you have classic symptoms from the Chiari, you treat the cause of the Chiari. If that's a small post fossa, you decompress the post fossa. If it's something else, you do the whatever else it is. Is EDS associated with craniocervical junction abnormalities? Now, Marcus was very clever. He sort of ramped up the questions. He did the ones he thought people would agree with, and then he got to a point where he thought, so he slowly built up. So is EDS associated with cranial? Yes, there was agreement for that. That it could be associated with hypomobility at this level, and the question is, can that then contribute to patient symptoms? And if you do something about it, does it help? There is a spectrum of craniocervical junction disorder severity. There was agreement there was. We know lots of people have hypermobility and live normal lives, or actually can be very functional and be very top sports people. So there is a spectrum. This was starting to get a little bit more difficult. How do you assess or how do you measure severity of the condition? And that becomes more difficult. So it was agreed that there was no accepted measure. There are some angulations, and maybe if you've got more of an angulation, maybe that means more, but actually it comes down to a link with patient's symptoms and the amount of angulation. So the next questions, and they were specifically set out to look at this difference between, can you see on a scan pressure on the brain stem, or is it just this idea that there's pulling and pushing causing symptoms? So can abnormalities here without neural compression cause headache? Now they said
yes. Yeah,
yes.
we agree, yes.
Agreement.
Yeah.
This was when it got more difficult, and certainly I had issues with 6. So it then became more difficult. Can it cause neurological symptoms? Have we got evidence that it's causing neurological symptoms? If you have, do they not always cause symptoms? Well, yes. Is there a role for craniocervical fusion in some patients with headache for neurological symptoms? And before we get to that, and there was a lot of debate about this. In the end, there appeared to be agreement that there may be a role for craniocervical fusion in a select group of patients, but it's picking what symptoms and signs you needed. And there was general agreement that craniocervical fusion for people with only headache was probably not the right thing to do or not a good thing to do. There's very little evidence. For patients with neurological symptom, again, the evidence wasn't there so much. So, and fusion indications, outcome measures are defined, they're not defined. There is some attempt now to define it, and certainly, as I said at the beginning of this ramble, the first 20 patients have now at least been published, and the people who have done more of these than anyone else, as far as I know, have at least agreed in principle to look at publishing bigger series of their patients. Because that's how we as clinicians learn. We learn from speaking to patients, seeing, but it's also looking at what works, because these people have had a learning curve. They've worked out what works and what doesn't work. So if we go on to some of the questions, now, does everyone follow that? You've got a sort of general idea of why people are interested in this and some of the issues associated with that? Yeah, well, people aren't shaking their heads too much. Okay. So the good thing about standing out here is I don't have to answer these questions. I get to forward this onto the panel. I think the first question, so why is Ehlers-Danlos syndrome so overlooked by doctors? Also, even when a patient is diagnosed with it, why is it so hard to find proper treatment? Would panel like to comment?
What number?
Oh, sorry, number 5. Number 5.
The panel jumping.
Don't all jump in. Well, I'll answer that to start with, shall I? Even though I'm not going to answer any questions. Breaking my rules straight off. So I think it's interesting because when I speak, as I say, when I speak to the rheumatologists in the UK, a lot of them don't accept it. They don't accept the 2017 criteria. They don't accept, and they just sort of ignore it. They've got enough things to do with people who have a genetically proven abnormality and all the other things, and they don't accept it. And so it is difficult. That's all I was going to say.
I don't think it is overlooked. I think it may be downplayed in terms of its contribution to particularly the things we're talking about here, but also there is no specific treatment. And I think Andy made the point that EDS, or particularly hypermobile type EDS, is not necessarily a disease, right? It's not necessarily a bad thing. There are some people who have advantages because they're hypermobile. So it's a spectrum, and not everyone who is on that spectrum has a disease that needs to be cured or treated. And then, of course, the problem, there is no actual cure. And so I think from my point of view, it's more about taking into account the fact that this person has EDS in terms of assessing them and then how we're going to manage them. But I can't specifically treat the EDS. It may influence what we do, but I can't treat it specifically. And that can sometimes be interpreted by people, I think, as meaning I'm not interested. Well, hopefully that doesn't come from me, but for other doctors maybe, it may be interpreted as they don't know or they're not interested. Whereas what they're thinking is, I know I'm interested, but I can't do anything about it.
That's almost exactly what I was going to say. I think with the lack of consensus about the diagnosis and the lack of available treatments, it puts a physician who's basically been born and bred to have answers and solutions and to be able to help patients in a really difficult paradigm. So oftentimes maybe we just kind of appear to ignore it when it's not that we are ignoring it, it's more that we don't have those answers or solutions or information. So we feel somewhat unhelpful or not as useful as we'd like to be.
Okay, I wouldn't be as positive about that. I must admit, I only really started hearing about EDS in the last 2 to 3 years in relationship to this, as coming to some of these conferences, and I know a lot of my colleagues know nothing about it, and don't see it as relevant at all. And I think we're in a very specialist conference where you're coming to it specifically to looking at Chiari and syrinxes, and we've got the people who have previously been seen maybe as the fringes of the medical fraternity, who are saying things that aren't necessarily accepted, are invited to take part in the discussion. And so I would say that there are a lot of people who don't know very much about it. Certainly in the UK, it may be different here, but...
But I still come to the point that there's nothing specific that can be done. And even if the doctor is not necessarily consciously thinking this person has EDS, in the end, it probably doesn't change what is done. So even if they don't know or recognise it.
Oh.
Can I piggyback off of that? It would change. Oh, I don't want the mic.
Yeah.
But wouldn't knowing that a patient has Ehlers-Danlos possibly change the approach that you would take, understanding that there may be complications or longer healing times or wound treatment? Wouldn't knowing that, though, help you?
Yes, although I come back to that first question on here. Everybody agreed they would actually do exactly the same thing for a person with EDS with typical Chiari malformation.
We consider everyone as possibly having EDS because we'd like to identify them. We just use the Baton score, which I think y'all are familiar with. Also ask about hip dislocations or elastic skin and those kind of things. If there's any suggestion, then they're going to need to have a rheumatologist evaluate. Unfortunately, in many communities, that takes several months. Then I do a traction test. I have them sit. I go behind them. I lift up their head. If they say, "Can you just keep doing that?" then... or if there's no difference, especially lifting and letting go, it doesn't seem to be any different, but some people clearly are different. So then we send them for flexion extension sitting MRI scans. A lot of those are negative, and it's not a non-issue. At least it hadn't affected the craniocervical junction. If it has affected the craniocervical junction, right now I'm sending them to specialty centers. I think there's a misperception that these centers, and I don't know the actual numbers that they do, but what I would say is there's now evidence in the literature that it's hard to get an operation for that if somebody wants it. I mean, there are a few that, so Dr. Fraser Henderson has published online, freely available, in January of this year, his study that you mentioned, Marcus, on 20 patients. And the bottom line, if I can be very quickly, is they're reasonably selective. So you have to have a formal genetics evaluation to know that that's there. You have to have a severe headache greater than 7 out of 10 that's been present for 6 months. A cervical medullary syndrome, so they're not operating only for headaches. Nobody's going to offer that, or certainly these groups don't. You have to have other cranial nerve issues or long track issues, as we call it. The radiologic findings, of course, have to fit, and failed conservative therapy. Now, Dr. Henderson doesn't say how long he uses a collar, but I know some folks use a collar for 6 months. So they're trying to do everything possible to see, and the collar trial in particular is very helpful do you feel better when you're restricted? And so bottom line is I think they're being reasonably selective. Fortunately, they're starting to share information with us. We need more than just this. This is just 20 patients, this has been pointed out. But in my own experience of folks that I have, and the other thing to keep in mind, although it appears that they're doing a whole bunch of these surgeries, bottom line is they're national referral centers, so they're going to be getting folks from all over. But my own gut sense of people that I've seen in follow-up that they've treated, and it's only been a few, is that there seems to be a benefit in general, I don't know specifics, and limited disability from the procedure.
So I'm going to make this, I guess, a very controversial discussion, but I have a huge problem with this collar test. Huge. We are putting patients through a surgery based on the assumption that feeling better in a collar is isolated to the fact that they have craniocervical instability. But being in a collar, there are other patient populations that feel better in a collar. For instance, after a whiplash injury in a car incident, does that mean you need a craniocervical fusion? No. It's supporting muscles. What is it? Is it related to musculature and its weakness? Is it related to another segment in the cervical spine that could be contributing to it? And I know one of the criteria for the collar trial is that you have to feel better in it, and then you have to have worsening of symptoms out of it. However, we all know from treating patients, the longer you're in a collar, the more challenging it is to come out of that collar because of the fact that you're not using that cervical musculature, and there is a process by which you have to reacclimate yourself to not having that stability there. And I would argue that a craniocervical junction fusion is much more risky and complex than a Chiari decompression. It limits range of motion, you can hurt the vertebra. I mean, there's so many things that can go wrong. I just have a huge problem with that. I don't know how everybody else feels.
And I don't disagree with the length of the collar. That does seem to be a very long time. Many years ago, I treated a young woman from Florida, healthy, Chiari malformation, no surgical issues that we can identify, no leaks, no ongoing crowding, but she was miserable. She came back a few months later. I evaluated her. Everything looked open. Cine flow was normal. I did not identify anything. She came back another few months later. Dr. Oro, something's going on. Dr. Oro, I saw someone in a halo the other day. And I said, what are you trying to tell me? And I looked at that and I thought, wouldn't that be good? Okay, wouldn't that be good? So we treated her.
You might just need to explain what a halo is.
Oh, I'm sorry.
Yes.
So a halo is a ring around your skull with pins and a jacket. It's what we use sometimes for spine fractures or those kind of things. She was willing to wear a jacket. The only thing that helped her while she was waiting to find she ended up having her fusion in Florida was a collar. But I don't disagree that a routine 6-month trial is going to decondition you, and we have to keep that in mind. All I'm suggesting is that you don't walk into some of these centers, have the angles, and get scheduled for the operation, which is, I think, sometimes the perception. There's quite a bit of criteria, at least by Henderson's hands, that you have to, adhere to. Long term, we don't know.
We got a little bit away from your question there. Sorry about that. Yes. But actually, I felt it was worth letting it go because that's one of the cruxes of the whole problem, or one of the big discussion areas. And what I would actually plea, and I'm going to say this here, is that if any of the surgeons are doing this treatment, they really owe it to be publishing this and auditing their results and telling us, the rest of us, who it is that is better, because that's the way we find out how these things are better. Let's move on. Question 10 next. So question 10 is what is the best thing or things a patient with a hypermobile body can do to avoid requiring surgery? I'll open that up to the panel.
Spine health. Spine health is we're going to put additional stress if we're not taking vitamin D, and then, of course, this is usually in older folks, my age. Then you start having sort of a settling of the vertebra, and you see some older folks that are like that, and that could be vitamin D deficiency, calcium deficiency, et cetera. So spinal health and spinal balance. So the greater, maybe you've seen these pictures online, the greater the body, the anterior abdomen is, the more out of balance the spine. And so obviously that can be a source of pain. And you may not need a craniocervical fusion, unlikely to. What I'm trying to say is there are other causes if you're out of spinal balance. So that physical toning, letting your body keep you more naturally aligned is critically important. Some people are trialing these straps that you can get online for $20, $30 that at least remind you about the strength in your shoulders to keep that in. Yoga actually turns out to be a very good exercise for reminding us, because we walk around in a stoop posture. We've got these little devices in our pockets, and that's really bad, basically. So, if we're trying to avoid it, physical health and maybe therapy and some of those other things.
Renee, in children, what do you advise them?
I don't specifically advise them against anything, to be honest. I'm not sure I know of any particular activity that they participate in that would worsen their likelihood of having to have intervention. I do agree with the device situation. I have had a lot of, even outside of the Chiari population, patients referred for neck pain because children are having a tendency to always be on iPads or devices, and I think that is influencing that, but not within this specific population.
Maybe you should open up the question, but what do people find?
Yeah, okay, that's good. So I'll just explain that, and then we'll take your answer. So for everyone who can't hear, so the idea was what have people found is helpful in those who have EDS, where they've found specific things to be helpful? Yes, please.
So with my children, them not being able to really vocalize, articulate what they're dealing with, what we've found is physical therapy to work on the core, how you were talking about spine health, and then also body awareness and just knowing your limitations and not doing things to obviously make that worse. And I'm not going to go on a tangent, so I'll stop there.
Okay, so did everyone hear that? So physical therapy and body awareness. Anybody else want to make a comment?
So in my daughter's case, she has EDS. She has a Chiari.
Sorry, can people at the back hear that? No, would you mind?
Information. She also has a rare disease called spastic paraplegia, so she won the genetic lottery. She was seen by Dr. Henderson and went through the process of using the collar, which he recommended, and then also recommended that in that process of identifying if it would help, had to do physiotherapy with, first we saw Dr. Healy, and then we ended up connecting with our own medical advisor, Chris Pridmore, and she gave exercises to do muscle strengthening. So not just wearing the collar all the time, but putting it on and taking it off and using it at specific times. That helped with her symptoms, but it also took her out of that 20 patient population, because otherwise she might have had surgery, right?
Yes, hold on.
I actually find a very intuitive chiropractor that helps me weekly, kind of pop things gently back into place that
Okay.
have shifted, and I don't know how I feel about it.
Okay, thank you. Thank you very much. Should we move on? Oh, no, hello. Okay, that's okay.
I find dry needling to be very, very helpful, especially in conjunction with the physical therapy. There's some electrical stimulation as well. So when you use it directly before the exercises, I find that the gains are tenfold. That has been a game changer for me. It actually got me up out of bed, and I was really enjoying that work.
So this lady has said dry needling. Is that like an acupuncture type thing, or?
It is, yeah, it's similar, just directly into the muscle and the nerve.
Okay.
So it's acupuncture without the exam. To be an acupuncturist, you have to know over 1,000 points. It's a rigorous exam. So it's sort of the modern approach to somewhat similar to acupuncture. I do have a cardiologist runner at the hospital where I work who's having significant foot problems. And then a week later, after I said, "You're looking good," and he says, "Well, it's dry needling." So there's something. There are some studies beginning to see what the local effects are of it. So I think there is something there.
Okay. I'm going to move on to the next question, if that's okay. So let's go to question 12. But actually, there's a number of questions like question 12 that talk about upright MRI. And I know this isn't just for EDS, and flexion extension views. So if I could first ask the two panel members that have done the surgery or have been involved in patients who've had the surgery, do you think there's a role for upright MRIs in these, or flexion extension MR, or what is it that you use?
Yeah. So the DMX fluoroscopy, you're not going to see the craniocervical junction. It is a good video for cervical instability. In the medical community, we generally used fixed images, flex, hold, extend, hold, and then a neutral, because then we can compare results to different examiners. If you're assessing a video, all of you are going to see, we're all going to see something different, focus on something different. So there's just a different of technique, but I don't have any problems with the video. But because of the bone at the side of our skulls on both sides, we don't see the craniocervical junction. We just don't see it. So we have a protocol we have one sitting MRI in a large community of the Denver metro, and there Dr. Fraser Henderson published angles that are abnormal. And by that I mean that it's significantly abnormal. They're not using angle, say it's 150 degrees is the range of normal. They're wanting a person to have all the way to 135 degrees. So it's they're being safe, I guess is what you could say. In other words, if people have that, they're seriously out of the normal range. Okay, so that's another thing that's important. So we send them for flexion extension sitting MRI. There are a few people that have a pacemaker or whatever. You can get the same information to some degree with a CT scan. You're going to be put on something to flex you, and then a roll under your shoulder to extend you. It's not quite as good a movement. We measure the angles. And more often when I get those angles, they're normal, and I can reassure the patient this condition is not on the radar whatsoever. And occasionally we have someone that is more than 135. Again, that's fairly off the normal curve. And then I obviously send them for a second opinion.
Renee?
Being that I treat a lot of pediatric patients, I do think there's some role for X-ray. First off, in that you're able to see a little bit better the delineation of the bony contour, so as opposed to an adult who is more developed and mature. Also, when kids are lying down in an MRI scanner, it can give you the impression that they have a loss of lordosis, but their head, as opposed to adults, the ratio of their head to their body is much different, with the head being much larger. So sometimes it's just that positioning, translating the head forward, and they really don't have that loss of lordosis. So if I get an upright X-ray and do FlexX films, I think that's helpful to know whether that's really present or not. I do use on occasion FlexX MRI. It's not with an upright. Here in Buffalo, we have to do repositioning with pillows, but I have found that on occasion to be helpful, especially in patients who seem to have symptoms that correlate more with instability, saying, in certain positions I seem to have more symptoms.
Marcus?
A couple of comments. So upright MRI, in terms of demonstrating a change in the cerebellar tonsil position, is occasionally useful, but it's actually very uncommon in our experience that there's any change with a person upright. For me, that would be the main reason to use an upright MRI, is to check that if there's some uncertainty about that. In terms of the craniocervical junction abnormality, We tend to use flexion extension CT because it shows the bony anatomy much better, and a lot of these patients have assimilation of C1 to the occiput, particularly laterally, and you can see that a lot better on CT. What we're looking for is, you can see the angles very well on MR, but the mere presence of an abnormal angle doesn't mean that they've got hypermobility, because a lot of these patients have a very abnormal angle, but then you do a flexion extension CT and there is no movement. They've actually got assimilation of the skull to C1, and so it's hard to see how that sort of person would benefit from a fusion. It's the ones where on a flexion extension CT you see enormous range of motion between the skull and C1, where then you could make an argument that these people are going to be different with a fusion. The one thing that you don't see on flexion extension CT is whether there's compression of the brainstem. That's the one, you can sort of see it, but not quite so well as MR.
I completely agree. What we do, if there's any suggestion on the MRI that there could be a bony fusion, abnormal bony fusion, they all get a 3D CT scan, and then it's just like a model of your skull. You can rotate it, on the computer screen and really have a good detail of that.
I visited the Chinese group last month. They have a 3D printer in their office. So for patients with craniocervical junction abnormalities, they print a plastic model and they take that into the operating room and they use that to help them with the surgery.
Okay. What I'm going to do now, there's a few more questions. A lot of them are quite similar. I suppose the one that might be worth asking the panel before opening this up to what I was going to do was the last 5 or 10 minutes of the EDS session before we go on to the syringomyelia session was just to open it up for any particular questions people have that haven't been answered or haven't been discussed or they want to highlight. The only thing I think was there's a couple of questions on physiotherapy, chiropractor and osteopath and whether there's particular issues of not using these particular specialties in patients with EDS.
Yeah, I have a strong opinion on one of those issues, and that's chiropractic. And so during my training, which was a few years ago, I was we do a neuropathology rotation with the pathologist for 2 months, and I was asked to dissect the cervical spine of a woman, early middle age, and I was to look at the basilar artery of this specimen, basically. Her story is that she was in the chiropractic office. She did have one of those rotational movements up high of the head. She developed sudden onset of severe pain. The treatment was stopped. She was allowed to go home after things settled down a bit. She was noted to drive out of the parking lot, and the car came to a very shallow ditch just outside, and she had died. So I'm the student or the resident doing the dissection, and basically the concern is the vertebral artery runs through our cervical spine, and then it sits on top of cervical 1 before it goes up into the skull, and that feeds the brainstem, the 2 vertebrals. So it's got skull bone here and C1 there. It's right in that little groove. And what had happened is in the manipulation of the downward force, it partially tore the artery. What we found is what we call a pseudoaneurysm. So she did not bleed initially. And then when she rolled out of the parking lot, it looked like it ruptured and passed away. So there are a number of chiropractic deaths from that procedure. 2 years ago, an influencer, fine young woman apparently, that had a big, huge following, passed away from chiropractic manipulation. So, from my point of view, they can do some of their other treatments, but I advise against that rotational movement that has been classic in chiropractic for many years.
Well, particularly for EDS patients, because the range of motion is greater, and they may also have vascular wall weakness, and so they're going to be more prone to vascular injury with extreme rotation.
This is a very basic science approach to this, but we know that even in healthy kids, the cervical spine is much more flexible. And so I think that there is a bigger risk in kids as well with manipulations, and there have been some paediatric deaths from chiropractic as well. I guess from the basic science side of the neural injury, your nerves and your spinal cord and your brain are very sensitive to high-speed loading. And so one of the concerns about chiropractic is the rapid movements as well. I think there's a much higher risk of injury if those movements are rapid rather than slow. So I'm not going to comment on the actual therapy, but from a basic biomechanics and science perspective, you'd be very worried about kids because of their huge range of motion, and same applies to EDS. When you've got a larger range of motion, that can put more loading on your nerves and your spinal cord than you would get in a normal person. And anything done at a high speed, I'd be very concerned about.
I completely agree. In terms of the childhood patients, they're at particular risk, so their ligaments are more lax. The bony architecture of their cervical spine is different. It's not as mature as in adults. So some of the facets, which are responsible for holding parts of the spine together, are not oriented in the same way they are as an adult, and it gives them more motion as well. So I believe that it's particularly of high risk in children. Not to mention the fact, and I agree with what everybody has said, we had a lengthy discussion about this concept of where the symptoms from Chiari even come from. And one of the main theories was this stretch theory. And so if you're thinking that stretch is a phenomenon that's contributing to the symptoms, and now you're undergoing a therapy that puts further stretch on that area, I just think it's going to possibly exacerbate the whole thing.
But what I'm not hearing is that physiotherapy is something that should be avoided. So physiotherapy is something different. We're talking about chiropractic and specific movements at the craniocervical junction. Okay, well, let's open it out for the last 5-10 minutes or so to questions.
Was there any discussion amongst the colleagues in regards to EDS patients and stenosis of whether it's the venous or artery? Because I know there's some research that it's been controversial as far as stenting.
Yeah, that question is on the list, and I think that relates to the idiopathic intracranial hypertension. In fact, a lot of that original work and hypothesis came from a group in Sydney, and I think one of the largest series in the world comes from that group, and we work with them. I don't think there's any doubt that there are some patients with idiopathic, so it's not idiopathic, but intracranial hypertension that is caused by stenosis of the main venous outflow from the brain. There are some complex theories about whether there's an interplay between whether if you get an increase in intracranial pressure that narrows the veins, and then that makes the intracranial pressure higher, and so it becomes this vicious circle. But there are definitely some patients where a stent to open up that vein treats the intracranial hypertension, and that's all that's required. But there are many who don't respond to that. They have the stent, they might be okay for a while, but then they have recurrent symptoms and end up having a shunt. Whether that's more common in EDS patients, I don't know. I'm not aware of a connection, but that's what that's about.
If there's no more questions, there is one. Yes.
Disturbances in Canada involved in the only neurosurgeon that was available who was trained by Dr. Henderson and sadly was involved in right now
So, he's in prison. Yeah.
And we're looking at hundreds of people with EDS who are now at a crossroads, and I've had a number of patients
Can I? Yeah. Can I speak to that a little bit? In that, I think it's an issue in Canada that's quite visible because of the proximity to the United States and availability of these treatments, but it's not an issue that is confined to Canada. We certainly have that in Australia, and I know Andy tells me that's the same in the United Kingdom, where there are patients who are of the view that they would benefit from this surgery, but are not being offered it locally. Now, it's wrong to interpret that as saying that the surgeons are incapable of performing the procedure, right? We certainly do craniocervical junction fusion when patients have symptoms related to brainstem compression. Like, there's no argument about that. This is a definite indication for treatment for these patients. And so we do that surgery, and it's the same in Canada. They do the surgery. There are surgeons who are capable of doing the surgery. The,
And right now in Toronto is Dr. Lewis. Right now
The-
I'm talking about a lumbar fusion, and he specifically looked at the patient, shook his head, and said, "I don't feel comfortable doing this."
yeah, so it's not that they're incapable of doing the surgery. They're technically capable of doing the surgery. And as Andy said, surgeons like to operate. And I actually use this, I say this to my patients a lot, I like to operate, I would like to operate on you, but it's not the right thing to do. And so that's the issue here, is working out where the indication level lies. And I think that's what's happening in Australia, it's happening in the UK, and I think it's happening in Canada, is that the surgeons are not yet convinced that the indications are there to do this surgery for patients without evidence of brainstem compression. Right? If there's evidence of brainstem compression, we are all comfortable it's the right thing to do, and we're all capable of doing it.
I may not be correct in saying this, but I think it may be more extensive than that. I thought there was a whole host of patients who are scheduled to have surgery even and have been identified as being symptomatic and now don't have access to care. Yeah.
I think it's that the other surgeons don't agree that the indication is there.
I don't believe that's it, actually. I don't know if you can clarify a little bit more.
Yeah, so the doctor, the neurosurgeon that was doing operations on EDS patients had experience over a period of 2 years. He had collaborated in discussion with Dr. Henderson on specific cases. He had learned about the outcomes and the patient symptomology and what was being seen as improvements from surgeries. Unfortunately, in medicine, in surgery, you pick your area of specialty, and in that particular surgeon's case, he was a specialist in failed neurosurgeries and failed hardware, and agreed to take on the EDS patient population, which was fantastic and incredibly hope-inspiring for the EDS population specifically. So to not have him available any longer, and then to be put back into that category where there's this question of, is the nosology of 2017 right? How do we agree on diagnostics? And what is the criteria? Puts us back so far. And those patients, and there are a lot of them, that we are in communication with from a charity point of view all the time, and they are left to suffer in silence. They were scheduled for surgeries, and that doctor's senior colleagues supported him doing the surgeries, and if you call it pioneering or whatever, they just determined that they would provide the surgical OR time.
It's not, the surgery's not pioneering. It's the indications for surgery, right? And we're all very sympathetic. But if I bring you back to that pyramid of evidence, because something is being done that's new and if I can use the term fashionable, does not mean that it's established as the right thing to do. I mean, it could, if we all suddenly started doing this for everyone, and then in 10 years' time find out that all these people are actually worse off, then we have done a bad thing. And we don't want to do that.
And I'm going to try to be respectful, is that when you have neurosurgeons that are working in this area, each of you are part of that. We're so thrilled to be here because you are the experts and you're willing to talk about this problem in the EDS patient population. But in our world, there is highly unscientific discussions happening from the doctor to the patient that leaves them feeling like they don't know if it's indicated, and they're not listening or talking or communicating. They're using, I don't even want to repeat the words, that are descriptive adjectives about what one surgeon would do over another. And to us, it's not professional, it's highly unscientific, and I'll finish by saying thank you for being here and encouraging this conversation among the neurosurgeons in the world.
And I think rather than go on more about that, maybe what we do is a couple of the questions actually said, well, how do we move it forward? What do you need to do so other people understand, other people, other surgeons know about it, number one, and also how do you convince people that it's something that can help in a proportion of patients. So over to the panel.
I have,
Oh, go on.
you just raised an interesting point. In a portion of patients that it could help, will that need to be established before people are willing to intersect? That's where my big crux would be a question, right? So will we need to have enough high-level evidence research, right, all the way to, you know, those comparisons out in the pyramid that you shared, to demonstrate which portion of patients will benefit before action would happen? That's just my curious question, right? Because my child's living it as we're all learning it. So it's a difficult learning curve when you're on the path of watching progressive, pervasive disability and know there may never be an intervention in her lifetime if we're waiting for high-level evidence.
Okay, well, over to the panel.
It's such a difficult question to answer because the highest level of evidence is if you take a group of people with the same conditions, same characteristics, randomly assign them to 2 different treatments, blind them to that treatment so they don't know who has received what, and then follow a very specific set of objectives that you're looking at. And that's a very difficult thing to accomplish because that would require us taking 2, for instance, in the EDS population, whether fusion is necessary, would require us getting a cohort of people that everybody, first of all, agrees may benefit from a fusion, which we're still in contentions about, and then putting them through a procedure that would require us taking them to the operating room, opening them up, and at the point that you would put the hardware in, opening an envelope and saying, oh, this person's going to get it and this person isn't, closing back up. And you're never going to get, number 1, patients to recruit to that, number 2, an IRB probably to approve that. So I think the highest level of evidence to support this is probably, you're right, unattainable. But do I think there's value in taking the patients that have been treated by these physicians who are performing it routinely and trying to dissect what characteristics do seem to improve on a regular basis and have objective measures to them? Yes, and that's what we're lacking right now, is that we don't have, other than this 20 patient population that's been presented, a lot of information about the patients' outcomes that have been treated with this.
So I'm going to make one, again, scientific research sort of perspective on this. In most areas of medicine, when you are trying a new therapy, most of the time people should be enrolled in a clinical trial. So if you're trying a new device, for example, you aren't even allowed to use that device as a medical device unless it's part of a clinical trial. And I would argue that maybe I would like to challenge the neurosurgeons to try, and including those who are doing these surgeries, that if you're doing, and as a patient, you could follow that up with your surgeon. Are you documenting this? Are you doing this new surgery or this new procedure as part of a research study and a trial? So we do get the evidence and really encourage that. And we do that within the community. There have been a very small number of completed proper blinded randomised controlled trials in surgery. And I have to say that most of the ones that I've seen have suggested actually that the surgery is ineffective when there's been concern about it. And a famous one is a fairly recent, very large trial of knee arthroscopy, which is a very widely done procedure, and it actually showed that there was no effect of the surgery on knee pain or outcomes. So you have to be willing to accept that the surgery the trials may or may not show that it's effective, but we really need that evidence, and the case studies are the first step in that.
But I think, Lynn, you're not talking about necessarily having a randomised controlled trial for these people, but that if these people are being treated, they're being treated and there's care looked at before and after and working out and publishing that.
That's very definitely the first step, is to absolutely document and follow all these people are having different surgeries.
John?
And on the issue of moving forward, imagine what's happened over the past few days. You've heard something about it, but that's only going to happen once a year. And we're a very small group of folks out there you're seeing, et cetera. So we do have what we all know is, and maybe too much, social media, but it does beg the question of how should the medical community in this area use that very powerful technology, which is something that I'll dedicate effort, hopefully with a lot of collaboration coming on up. I have long-term experience on the development of neurological internet sites. So from this discussion, I see two steps. One is a closed community of medical providers that are willing to hash it out and debate the evidence and be up in your face if needed for their opinion. And that could be an ongoing community that grows, that pulls in neurologists as we can and other practitioners. By the way, I will say that we need more nurse practitioners in this field. They're invaluable. They have a wider perspective than physicians that are specialists. And again, they're invaluable. So one would be, how do we carry on this dialogue amongst the professionals and bring in more professionals? And to me, it's got to be an online community. But then, what's the next step to get the basic information available to all of us? So you can find a reliable source online that's been reviewed by peers, if you will, that's agreed upon, that's presented in a way that's understandable to a non-surgeon, if you will, etc. That is not impossible. I've taken a tiny stab with chiarimedicine.com. It is, I haven't updated it, so I've had to choose in my profession, but I'm committed, hopefully with a number of other people, to see will these approaches help us go beyond the current state that we're at. On the other hand, I'd like to finish up and basically say that it's the high-level trials, as has been pointed out, that eventually will clarify things.
Marcus, do you want the last word?
I knew this was going to be the controversial topic when we got to it, right? And if I could just tell a story, as I said at the beginning, medicine is full of examples where things were adopted as fashion and then turned out to be the wrong thing to do. An example is brain bypass. So this is a few decades ago, that an operation was developed to connect an artery from the scalp onto the inside of the skull and increase the blood flow to the brain. And this became a very widely performed operation for people who'd had a stroke or had had a mini stroke in order to prevent stroke. In fact, it became one of the most commonly performed operations in the United States. And patients may have been in a position of feeling aggrieved if they had not received this operation. And then a big randomized controlled trial was done that showed the patients who got the bypass were worse than the patients who did not have surgery. And overnight, John, that was probably in your beginning of your time. So yeah. Overnight, the operation stopped. Mm-hmm. And then, of course, what's turned out is that that's wrong too. Mm-hmm. There are some patients who benefit from the bypass. And so the lesson here for me is that we need to be approaching these things in a careful, considered way and constantly evaluate results, constantly ask the question about what's the right indications.
Yeah, but the opposite is also true. So we used to think that in everybody, stomach ulcers were stress. I mean, I grew up in the stress. I believe it was an Australian that pointed out it was bacteria for a lot of people, H. pylori. But he was thought to be totally fringe, held on to his studies and beliefs, and now we know that that's the case. So the opposite is also true.
But he proved it by swallowing the bacteria.
All right, don't self-research. Yeah, that's true. I know.
Yeah. Don't put screws in yourself. And I think you should know you're not alone. This is a common problem in neurosurgery where most of the things that we do don't have a lot of evidence-based factors to them. And one of the main areas of contention is spinal hardware and instrumentation. So for instance, if you have a lumbar spine problem and you see 10 neurosurgeons and 5 orthopedic surgeons, you're probably going to get 15 different answers, and there's not one that's necessarily right, and there's not 14 others that are necessarily wrong. We just don't know. And medicine has headed so far down that pathway, you can't reverse it anymore. So people are doing things based on their experience and talking with others without a lot of level 1 evidence, and I think that's kind of the position that we're in now too.
And I'll just repeat that it's not the technique of the surgery that's the issue. This is widely available surgery. It's the indications for surgery that's the question. It's not that we're incapable.
Thank you very much. Thank you, everybody, for contributing to that part of the discussion. We're now going to move over to the final area, which is for half an hour.